Hello everyone and welcome to Kinedy. Today I have the pleasure to interview Peter O'Sullivan, physiotherapist in Western Australia who has specialized in dealing with chronic pain. Peter will take us through the concept of chronic back pain and the concept of cognitive functional therapy, or CFT. What is CFT? How does it work? And how can it help with chronic pain? We dive deep into those questions with Peter to understand the positive impact of CFT on treating pain. We compare CFT with manual therapy and exercise on pain management. Peter takes us through the clinical examination and basic screening for each new patient that comes into his clinic. And then he tells us about a patient of his that came in last week and the patient's story, and how Peter approached the patient's pain, what questions he asked, and the suggestions he made to reduce the patient's pain through guided behavioral experiment. If you like this episode, make sure to share it with your friends and colleagues and subscribe to the podcast. Also, you can leave 5 stars to help us grow. Today, I'm very happy to welcome Peter O'Sullivan. Hello, Peter.
Hi, how are you?
Good. Thank you so much for participating in this podcast.
Yeah, thanks. Nice to be with you.
Likewise. And so it is 10:30 in Europe and it is 4:30 p.m. for you.
Yeah.
You are in Western Australia, correct?
Yeah, Perth, West Australia, the most isolated city in the world, which up until COVID seemed like it was a bad thing. But during COVID, it was a massive advantage.
All right. You didn't have too many restrictions during lockdown.
Basically there are 2 roads into Western Australia from the rest of Australia, and they block both of them. So we were an island within an island, basically, and we lived pretty much a completely normal life, feeling guilty with what was happening with the rest of the world, but we couldn't go anywhere outside the state and no one could come in. So literally they just locked the whole state, and it's the size of Western Europe. Like West Australia is huge, massive
Yes.
landmass. Yeah. Literally, we had that space to be in. It's kind of weird, but we were extraordinarily grateful and almost felt a bit guilty that we were living a normal life and we were watching what was happening in the rest of the world. It's crazy.
Well, it's good you had the good end of the stick. Good for you.
Yeah, totally. Yeah, exactly.
Yeah. But you're not from Australia yourself. You're from New Zealand, right?
So I'm a Kiwi. I grew up in a small town in New Zealand in the north. I did my physiotherapy training in the south in Dunedin, and then worked for 3 or 4 years and realized I needed to either get out or do further training, because I felt like I was a jack of all trades and a master of nothing. I'd done every workshop that was possible to do for a graduate physiotherapist. And I really felt like I just learned a whole lot of techniques, but I didn't have a deep understanding of what was going on. And that really unsettled me. So I ended up going to came here actually to do a training as a manual therapist. It was a graduate diploma back then. And then it sort of set me on a quest to do research, because I was like, we know so little about this problem of pain. There is very little research available. And so I started doing a master's degree, then a PhD, and pretty much my entire career has been 2 streams. One, working in the clinic where I spend half my time working with patients with pain. And the other half of my time is working as an academic where we do research and I'm involved in education at Curtin University.
Okay, very good. And your research is mostly focused on chronic lower back pain?
Yeah, chronic pain, actually. So we have done a lot of work around chronic back pain because it is the leading cause of disability of any health problem. But we are extending that work beyond back pain into arthritis, into other pain problems, because the model of care we've developed for chronic back pain sits so well with the management of chronic pain in general. And so that's kind of where our stepping stone is going now. Certainly as a clinician, I work with any pain, any chronic pain, be it TMJ, ankle, knee, hip, shoulder, it's pain. Has very similar characteristics in terms of, what the risk factors are for developing chronicity, and the management strategies that we know are important for recovery look the same irrespective of where it is in your body.
Do you work half time as a researcher and half time in your clinic? How do you organize yourself on a weekly basis?
No, so Monday, Wednesday, Friday, I do 3 sessions in the clinic, and then Tuesday, Thursday, and at one afternoon, I do academic. So I kind of alternate my days.
Mm.
Yeah.
That is pretty cool,
It is
right?
very
You
cool.
get
Yeah,
to.
it's really cool. And
Mhm.
I think what it allows us to do, what allows me to do is I kind of sit between these two worlds, the world of research where we explore questions and we can develop hypotheses and test them in a research way. And then in a clinic, I can develop hypotheses with an individual and test them with an N of 1, essentially. So both of my worlds are really around hypothesis testing. One is with an individual through their own journey, and the other is from a research perspective, where we look at both qualitative research, the story of an individual, and we run clinical trials and do epidemiological research as well. So we use all kinds of different methodologies to answer questions that are important
Mhm.
for both patients and clinicians.
Yeah, it's interesting to see both ends of the spectrum,
Yeah,
the research side and then the clinical
yeah,
aspect. Yeah, of
exactly.
course.
Yeah.
Do you work in a pluridisciplinary clinic with other physical therapists, or is there a
Yeah.
specialty?
Yeah, so we have a number of therapists in our practice. So we're mainly musculoskeletal pain. But we have a broad range of, we have sports physiotherapists and pain physiotherapists and musculoskeletal physiotherapists, predominantly all working, and then vestibular. We also have a psychologist who we work with, who we see some of our really, really complex cases, complex trauma, people with anxiety disorders, major depression. So we work in tandem with them. We have every week we have a team meeting where we come together and we talk about really tough cases and how we can better support people with pain. So it's fun. So it's a wonderful place to work.
Yeah, it does sound like it. So, if you don't mind, we'll go straight into the topic I want to talk to you about today,
Yeah,
which is cognitive functional therapy.
yeah,
In the paper you mentioned in the masterclass that's available on YouTube, a
yeah,
paper published in 2012 in the European Journal of Pain on non-specific lower back pain. It is comparing cognitive functional therapy, so I'll call it CFT,
yeah,
and manual therapy and exercise. And the study proved that the CFT was more efficient in regards to the reduction of the intensity and disability of pain compared to the manual therapy and exercise approach. So my
yeah.
question is, should we all take the CFT approach towards chronic lower back pain, or what is your intake on that?
Yeah, so I think I'd probably step back from that to say, what do we know about the causes of chronic back pain? And what are the mechanisms of recovery? So, if we think about what we know about chronic back pain, um, we know it's really common. It's the leading cause of disability in the world of any health condition. We know that what you see in a scan doesn't predict what you feel or how much disability you have very well. So, it's not just about structure. We know that a person who can develop acute back pain, around 25 to 30% will go on to develop a chronic problem. We know the predictors of that person developing a chronic problem are linked to often quite catastrophic thoughts around, this is a terrible problem, it's not going to get better, it means that I'm damaged, I need to get a scan, that whole process. And then that can create distress and fear. If the person becomes distressed and frightened, they then become overprotective and start avoiding normal activities and movements. And that sets up a loop, a vicious cycle of pain and disability. There's really strong evidence for that. So if the drivers of disability are linked to the way that people think, their emotions around pain and their disability, we need interventions that explicitly target those things. And that's what CFT does, essentially. So within a CFT framework, which is very adaptive and centered on the person. It goes, what are the key things and elements that are driving this person's pain and disability? And it will explicitly target them around the 3 domains of treatment. And what we know about recovery from chronic pain is that the things that need to change are, you need to change how someone thinks. So a reduction in something like pain catastrophizing, a reduction in fear, and an improvement in pain self-efficacy are linked to improvement. And they are the things that we explicitly target in the treatment. So I would say to a clinician, if your treatment for chronic pain is manual therapy and exercise, are you explicitly targeting people's thoughts, emotions, and behaviors in the way you treat? Because if you're not, they may not get better. So it's kind of, rather than saying this treatment's better than that, it's really going, well, what do we know about what causes a problem? And what do we know that has to change for someone to get better? And what's the best way I can do that? And what we know from the research is that you can build someone's self-efficacy and shift their beliefs and reduce their fear through exercise. But are we doing it explicitly? We might be able to do it through manual therapy. But what if the person's had manual therapy and they've had general exercise and they're still not better? What are your options as a clinician? You need something else. And we know there are lots of people like that in our community who have been through the system. And most of the people in our trials have been through primary care and have been to physios, chiropractors, osteopaths, seen the doctors, taken drugs, had injections, might have had surgery, and they're stuck. What do we do with those people? And that's really what we've been targeting with our interventions.
Very interesting. Can both manual therapy, exercise, and CFT work hand in hand together?
Yeah, so that's an interesting question, because as a physiotherapist, I use my hands. Like I am trained as a manual therapist, right? So it doesn't make a lot of sense that if I have a patient who comes to me and they tell me their story and they say, look, I've been trying these exercise interventions and I've had lots of manual therapy and I'm not getting better. It would make no sense for me to give them the same treatment. It'd be like you going to the doctor and say, like, I've had this antibiotic, and we go, we'll give you some more. It doesn't make sense. So as a clinician, I've got to, and I realized this early in my career, where I had manual therapy skills and I had exercise skills, and there were lots of people I couldn't help. And so I was forced as a clinician and as a researcher to broaden my toolkit, because I realized that those techniques worked for some people, but there were a lot of people it didn't help. And so rather than saying, can I just add something else into my toolbox, I would say, what is the best skills you can use to help that person in that position in their life at the moment? And I think what we know about all the evidence is that teaching people to develop mastery over their own health condition, teaching them to self-manage their condition, giving them a sense of confidence to get back to the things in life that they value, that's the skill that I reckon any clinician should develop if they're working with someone with chronic pain.
So what is the process when someone comes to you and tells you, I have seen a lot of clinical therapists, I have done a lot of exercise, and what is the process? And I'm stuck.
And look, if there's one paper that I would encourage your listeners to look at, it's a paper called Lives on Hold, which I can send you the link, by Sam Bunsley. She was the lead author, and it describes the stories of people with chronic pain, the lived stories. And it's a sad story of, trying all these treatments, being told negative things about their body, of losing trust in their body, of feeling dislocated from their world, of losing confidence, of feeling like their lives are stuck on hold, and not seeing a way forward. That is the story of so many people. So what's a typical scenario? If someone comes to see me, the first thing we do is we do basic screening. So we screen for red flags and serious pathology, because we don't want to miss cancer, infections, fractures, cauda equina syndrome. We don't want to miss bad stuff like that.
Yeah.
So we don't want to be reassuring someone who's got some underlying pathological process, a malignancy. we also ask them about their goals. What are your short-term goals and long-term goals for your care? And the short and long are really interesting because often people go, I want some pain relief. I'm in pain and I want some relief. Usually they're not always, but usually their long-term goals are, I want to get my life back. I want to get back to work. I want to play with my kids. I want to be able to go and walk on the beach. I want to, do stuff that gives my life value. If it's an older person, I want to keep my independence. I want to get back to exercise. I want to get sleep back because I can't sleep with this pain. They are usually the things. And it's so interesting. Often as clinicians, we get focused on pain, but actually it's people's lives that we're trying to influence here. So we will capture that, and then we get them to fill out a screening questionnaire. We use the Orebro screening tool, which was developed by a pain psychologist, Steve Linton in Sweden. It's a 10-item questionnaire. It's really simple. Asks about where your pain is, how severe it is it disrupting your sleep? Can you do basic activities, daily living? What's your level of stress, anxiety? What's your mood? Do you think you can work with your current pain? If pain hurts, do you avoid the movement and activity? Do you think you're going to get better? So these are tapping into, pain, disability, emotions, beliefs, and, beliefs around work, beliefs around physical activity, beliefs around your future prognosis. Now, we know that those factors are really important. So if you're scoring high on that questionnaire, it's highly likely that person is both highly distressed with a negative belief system around their body, and are disabled, and they're not sleeping, and it's disruptive of their life. So that gives you a really very quick insight as to the kind of, and then we get them to fill in their pain diagram as well, like, where their pain is in their body. So that's what I get when I see someone who comes in to see me. So I've got that as a printout. They fill it out online, and then I review it. They might have had imaging as well. I would have a look at that. Then they come into my room, and my first question is, can you please tell me your story? Everyone has a story, and I'm interested in their story. And I'm interested in, where it all began and what their journey's been like, because these people come with a whole story that no one's asked them to tell their story. They often say, oh, where's your problem? Or what can I do for you today? They don't say, hey, tell me your story. And often what you'll hear in that first minute, you'll hear something really important in their story. My story began when I was 15, and, it was a terrible time in my life. Or my story began when my marriage broke up. My story began when I had a terrible life-threatening injury. My story began somewhere. Or my story is I'm getting old and my back's failing me and it's crumbling, and I've had got pinched nerves, or I've got a back of a 60-year-old. Like, something important happens, and we'll come out of that story. And then we track, it's very patient-centered around exploring the impact that their beliefs around their pain, their emotional responses around their pain, their behaviors around their pain, their perceptions of their body. So it's a very holistic, person-centered approach of going, put me in your shoes. Tell me how it is to live in your shoes for a day. What's the pattern to the pain? Is there a pattern to the pain? The things that hurt it, the things that relieve it. What's your belief in your ability to get better? How do you think I can support your journey? What are your goals around recovery? And some people I see come in, like I had a 53-year-old guy last week, who was profoundly disabled and depressed and had no belief in his recovery. He had major spinal surgery. He'd been told it was just something he had to live with. And he said, I feel like I'm an 80-year-old and my life's come to an end. So that's his story. The other stories that we get people coming in with. And so after unpacking that, we go, tell me the things that hurt you, the things that you fear, or the things you avoid. Let's explore them. So our physical examination is very functional. We explore the things that are the barriers to recovery through the examination. And often during that time, we'll go, hey, So for him, it was like, I can't sit, I can't stand, I can't bend, I can't lift. And his goals were things like, I want to play with my cats. That was a goal of his, but I can't, because I can't sit on the floor, I can't bend over, I can't lift, so I can't play with my cats. That was one of his goals. I can't sit for any period of time, so I can't work. So another goal was his ability to sit for a period of time. And what unfolded in that examination was that he was so tense and so frightened and so distressed, he couldn't relax his body. And when I said to him, what's the feeling you have in your body? I feel like I've just got these claws that are just clamping me all the time. It's muscular. And so what we know about fear, what we know about distress, what we know about a belief that you're back screwed is that your body will go into protective mode subconsciously and consciously. And that becomes part of this loop where you just get trapped in it. And so across that whole examination process, I was able to say, hey, what if we get you to relax your body? What if we get you to break those rules that have governed you, that have left you in a prison to say, oh, you can't bend or lift with a straight back, or you got to brace your core. Let's get you to relax your core. Let's get you to relax your body. It's safe to bend your body, your back. It's safe to move naturally without protection. And then over the course of that session, he realized that doing that caused less pain. He was expecting it would make him worse, actually caused less pain. And that's what we call a guided behavioral experiment. And then at the end of that session, we could go, hey, let's make sense of this for you. Let's help you make sense of this through your story and your own experience, and map an understanding of what's going on in your situation, that actually you're thinking you're screwed, you've lost hope, you're sad, you're socially isolated, you're frightened, you're avoidant. And that's created this whole wind up in your nervous system, which is pain and distress and depression, and you're not sleeping. And that's the story of people's lives. And we can expose that and isolate it and then map a process. And he, at the end of the session, he shook my hand and he said, I can't thank you enough for what you've given me today. You have given me hope. You've given me hope that actually I can change. You've given me hope that actually can learn to get back some of the things in my life that give me value, that my life will just not end. He saw himself coming to a hard end of his life with no hope. Now, manual therapy can't do that. I'm trained as a manual therapy. I've taught as a manual therapist. Those skills never gave me that ability to take that person on a journey like that. And they're deeply rewarding as a clinician as well. They're not just, these are really, I think that's the lovely part about the work that we do, is that it's both rewarding for the patient and the clinician to be part of that transformational journey.
Absolutely. There's a big psychological aspect to it in the psychological.
Yeah.
Yeah.
We know it is.
Yeah.
I mean, you can't. And I hear people saying, oh, that's not a role for physiotherapists. Well, I'm saying, well, don't work with pain then, because I don't know if you've had pain in your life. I've had heaps, and you can't not have pain without emotion. It doesn't happen. I mean, to be fair on that, I've done some relatively extreme sports, and I've had pain in my body achieving, pushing myself to the limit. And that emotion is probably elation. But when you have pain that you don't understand, that's scary or that's threatening, that's got a whole different meaning.
Yeah. And so to go back to that patient, would you see him again every week until?
I'm seeing him this week.
Yeah.
No. So the typical process we take people through is around self-management. So I've given him strategies to work on this week. He's got a plan, and I'll review him again this week, and then I'll see him 2 weeks after that, and then I'll see him 3 weeks after that. So we literally just start creating space. So we go, yep, we've got you. We'll build on the plan. We're going to build your skills up, build your confidence. So his plan for the week was to do some reading and listen to some stories of other people with pain, to give him a different insight, to build some hope. Gave him some strategies to learn to sit and relax, learn to start bending his back more naturally, get out of the house, going for some walks, just start to, build some confidence back in his body, really breaking habits actually, and then mapping a bit of a pathway to go, tell me about the things you want to get back in your life. Let's pick them off. So for him, sitting more would be one of the things we'd reassess. Him playing with his cats, his ability to bend naturally and use his body, and not to have to avoid doing stuff. They're the things that we would assess. And then once he's achieved them, what's your next goal? So we chase the goals. So it's all about valued living and getting people back to do stuff in their life that they value. And, it's so interesting. I think of patients who I bump into, or people who send me emails or gifts. They never, ever tell me ever what their pain score is. They will always tell me about something that they've achieved in their life that they didn't think they could ever do again. They've climbed a mountain. They're playing golf. They're playing with their kids. They've gone for a run. It's always stuff that they value. It's never about their pain. Never about their pain. And I think that tells you something about where we have to be thinking as clinicians, because we get so fixated on the pain and we forget the person. But actually, it's the valued living stuff, which is the end point of their goals, which is the stuff we've got to be really focused on.
It's important to have an objective and a goal, right? We all thrive for that.
100%. Yeah, it's what drives us as humans. Yeah.
And those people, is there a certain amount of people who suffer from depression with chronic pain? And
yeah, it's really normal. Yeah. So there's a very kind of bidirectional relationship between pain and mood. So we know that if your mood is low, you're more susceptible to pain. And if you have pain and it takes you away from stuff you love, and maybe it's disrupting your sleep as well, it's a big driver of mood. So typically, if you start losing stuff in life you value, so if your values are linked to engaging in physical activity, going to work, playing with your kids, and you start losing that, it will naturally impact on your mood. But also pain is very distracting. Like this chap last week, he said, I just can't concentrate. He said it's literally trying to work for over an hour is like two people with loudspeakers blaring in my ears. I cannot think. So that is really distressing and exhausting for people. And that also impacts on their mood. And then he's like, I can't sleep. I'm like sleeping 3 hours a night. I'm exhausted. That impacts on your mood. So you start looking at things that will impact on mood. Pain is the perfect thing. Chronic pain is the perfect thing that really drives mood.
Yeah.
But in the same way, if you give people hope, and you start getting them back to doing stuff they love, and they start sleeping and relaxing and moving and re-engaging with the world, that boosts their mood. We have those tools in the toolkit. Re-engaging in physical activity, engaging socially, boosts mood. So we will explicitly target those things in our care.
Do you use breathing techniques? Do you guide them through?
100%.
Yeah.
Yeah, of course. And, we don't do them indiscriminately, but the breath is really interesting because we know breathing is really linked to your sympathetic or parasympathetic nervous system. So when you're frightened, what do? We start breathing rapidly. If we're anxious, if we're frightened, if we're distressed, we will manifest that in the body. And we often manifest that through our breath and through our body tension and through our body posture. And so we work a lot with the body. People often think this is talking therapy. It's very doing therapy. So if someone's distressed, like for him, for example, he couldn't sit, but he's sitting all tense. His breathing was very rapid and upper chest. And we go, okay, just get you relaxed. Slow your breathing down. Focus on a long out breath. Use your diaphragm. And straight away, his pain levels dropped. Just doing that. Like it is like a volume switch on the nervous system linked to your breath. And that's with resting pain mainly. But the other thing we see is that when people engage with movement, they hold their breath. And it's part of their protective mechanism. So they often use intra-abdominal pressure to tense their core, co-contract the muscles around their back. So they fix their diaphragm when they move. So you often hear people breath hold when they go to bend or lift or get out of a chair or roll over. And so we'll use breathing techniques to break protective mechanisms, these protective behaviors, whilst they're engaging in functional activities. And that's also very powerful way of kind of breaking these protective, unhelpful, overprotective processes in the body.
That's really interesting. Yeah. In your masterclass, you talk about negative language that can have a really big impact on the patient's mindset. Sentences like, people are told, oh, your disc is degenerated, you have a very fragile back. That can be catastrophic and have really bad long-term consequences. How do you approach a patient who's heard this so many times and who's so scared of moving? You have to change his mindset totally.
Yeah. So usually it's through behavioral experimentation. So if a person believes, like for this guy, he'd had a disc replacement actually, but told that the levels above were degenerate, and he felt fragile, and the belief that he needed to protect his back. But through that behavioral experimentation of getting him to relax and move and realizing actually he felt less pain, allowed me to then reflect back to go, what does that tell you? You're actually not protecting your back and feel less pain. What does it tell you about your back? And his response was, it tells me I'm not as fragile as I thought. So we use behavioral learning as a mechanism of the person that we say to people, it's harder to argue with your own experience. It's really easy to argue with someone telling you something. So we use experiential learning as the deepest way for people to contradict their own beliefs. So they actually believe, it's a bit like saying it's safe to fly in that plane. But if you just told it, but you don't believe it, you actually have to fly the damn thing to realize it was safe. In the same way, you can't talk people into being fearless. They have to engage with the activity and realize that their expectations weren't met for them to update that belief. And so what we often do is teach safety in the body with what they believe. They have fear in the body. We teach safety in the body. And that makes them reappraise their own beliefs. They're like, shit, I thought that my back was going to explode. I thought my disc was going to prolapse. I thought my nerves were going to get pinched. I thought that if I didn't hold myself together, my unstable joints would fall apart. Like, people have these beliefs, and we test them through behavioral experiments to go, actually, let's check that out. But you have to be a very skilled and empathetic clinician to do that, because you can't just force people to do scary stuff, because it can make their fear and anxiety worse. Actually, their pain could ramp up. So it's a really delicate process to take people back into feared and avoided activities and movements.
You usually the patient lies down on the table at first. You work on the breathing, and then you, for instance, no? How does it work? Someone who doesn't want to bend, for instance.
So if someone has a lying down problem, they have a sleep problem. So like, I'll give you an example. A chap who came in a couple of weeks ago, his main problem is he can't sleep. So he wakes up in pain, his whole back locks up. So I then examined him lying down, because he has a sleeping problem. If someone's got a sitting, standing, bending problem, like the guy I saw last week, I didn't lie him on the couch at all. So you lie people down if they have a lying down problem, or you cannot get them to relax in a weight-bearing position. You may start in a non-weight-bearing position. It's a very good position to teach people to relax in. But if we can train them functionally to engage in the things, if we can teach them functionally, we'll do it straight away. So we go straight for the functional activity. If they can't develop mastery in it, we'll back it off until they can develop mastery, then take them back to it.
Interesting. So you take the cause of the problem and slowly introduce them back into it.
100%. That's how you develop mastery over anything. If I don't know what you've done in your life. Have you learned to do anything scary before? What have you learned to do?
Oh, the top of my head right now.
Rock climb or
no,
ski or
skiing, yeah.
You're from France. Oh, yeah, right. So how did you learn to ski? You go on the beginner slope, you then go intermediate, and then you start going into more higher slopes, and then you do some moguls, and then you do some tree stuff, and you slowly build confidence to engage in scary stuff, right? That's how you develop skills. That's what we do with patients. We go, okay, so tell me what you can't do, link to your goals. Let's explore what it's like for you to do that. So it's like being a coach to build confidence, to build a sense of self-efficacy, to engage in things they thought they couldn't do. And the beauty thing with pain is you're never teaching a skill they've not learned before. Like most of these skills are human beings learn in the first 3 years of life.
Yeah.
And all we're doing is reteaching them something they've learned before, because presumably they learned to roll and bend and lift and walk and do normal stuff before they even thought about their bodies. And what we're doing is rebooting the system. Pain is so disruptive of normal processing. And when it's threatening and it's scary and distressing, it just screws the whole system up.
Yeah.
So we're taking them back to develop mastery again. It's like riding a bike. It's like if you've ridden it before, you can ride it again. If you've skied before, you can ski again.
That's true. Seems logical.
It is.
Yeah.
It is. It's very logical.
In regards to imagery, sometimes patients come with their results of imagery and they show protrusion, herniated disc, scary stuff. And it makes it worse almost. It increases their pain. How do you?
It can do. Yeah.
How do you reassure
there's good
them?
scientific evidence for that.
Yeah.
We do the same thing. So one of the things we do on with the examination is we make sure we're not missing something. So if someone's got a disc protrusion and they've got pain radiating down the leg, we do a full neurological examination to go, have they got power? Have they got sensation? Have they got reflexes? If they have, that's not relevant. And like we see this all the time with people who've got a diagnosis of spinal stenosis who go, oh, my nerves are being squashed. Or they've got radiating pain down the leg and they go, oh, I've got a pinched nerve. And then we go, actually, you've got really good power, you've got full sensation, and your reflexes are normal. That is not a pinched nerve. If you pinch a nerve, you will lose power and sensation and reflexes. You've got normal. So there is no sign of a pinched nerve. So that film does not tell me about your pain experience. So you can have leg pain, but it may be caused by something else. And we see that all the time. We know, for example, with lots of research has shown that there is a very poor relationship between what you see in a scan and what you feel. There's really good relationship with fractures. We know that if you've got a fracture, you're going to feel it right where that bone hurts. That's got a very strong relationship. If you've got an acute radiculopathy with a disc prolapse or protrusion or extrusion, there might be a much stronger correlation. You've got an infection, you're going to feel it. So there are some things we know there's a strong relationship, but for degenerate discs and disc bulges and facet joint arthrosis and annular fissures and all the other stuff that you see on a scan, they don't correlate well at all. And so we will explore that with the patient. And then again, through that behavioral examination, we'll test it out. We'll go, okay, well, if you've got pinched nerves, we can identify that. If you've got a fracture, you're not going to feel good to relax and move normally. You're going to feel terrible. Like it's not cool to walk on a broken leg. Like limping's normal and helpful if you've got a fracture. Same with protective guarding. That's helpful. That's when the body is protecting to allow for tissue healing. But for chronic pain, it's very rarely those things.
Yeah, very interesting.
Fractures heal. Infections, you'll be dead or paralyzed. Malignancies, the same thing. We have to be aware of things like, spondyloarthropathies and stuff. But even with those kinds of inflammatory disorders, the stuff we do actually helps. Re-engaging with, good sleep, regular physical activity, healthy lifestyle behaviors help dial down inflammatory processes anyway.
Talking about inflammatory diseases, autoimmune diseases and fibromyalgia, do you ever get patients with that and can you help them with CFT?
Yeah. So, back pain we know is really strongly comorbid with other pain. So if you've got someone with back pain, you've got a 10 times greater chance of having neck pain or headache. So they're really strongly linked. Back pain is really commonly linked to other pain. It's linked to arthritis. So it's just part of a pain picture. That's why we get people to put a body diagram. So if they start drawing their whole body, that's not about structure. That's about the whole nervous system is sensitized. When they start putting a line or a circle around the back, it's likely there will be sensitive spinal structures. And I think this is one of the misconceptions with our work is people go, oh, CFT thinks it's in the brain. It's not in the brain. These people have local tissue sensitivity, usually. You touch them and they jump. They've got local structures that are highly sensitized. So you can have nociceptive processes that are going on in your body in the absence of pathology. And I think physios often don't get that. They go, oh, if it's not pathology, it's in the head. It's not in the head. The pain's in the body. Your thoughts and emotions and behaviors will influence it, but they're still nociceptive processes that are going on. It just means it's not pathology driving them. So we know that if you're not sleeping well, if you're eating shit, if you're eating poorly, if you don't do physical activity, if you overprotect the body, that can set up local inflammatory processes that can sensitize spinal tissue. We know that's the case with arthritis. We know it's the case in back pain. So that can cause real nociceptive, and this is where probably Mark Laslett, he gets annoyed with the word non-specific. We see non-specific as a useful label for clinicians to say, actually, it doesn't mean there's not nociception. It just means there's not a pathological process going on. It just means it's not cancer. It's not infection. It's not a fracture. It's not a cauda equina syndrome or a disc prolapse. But there are sensitized spinal structures that you can identify through your examination that are influenced by all of these other things that we need to identify with that person. And so the non-specific is not something we'd ever tell a patient. It's just something that me as a clinician, I need to know that because I need to look somewhere else. I need to not worry about, because often it's the clinician that starts worrying, oh my God, I better be careful. This person's got a disc bulge or whatever. It's like, no, don't worry about that. Look to see the other things because we know they're really important to target in the care of a patient.
Yeah, interesting. So those people, for instance, with fibromyalgia, I can't say the word, and autoimmune diseases, that CFT can work well as well.
Well, there are principles around. So fibromyalgia, we know two of the key predictors of fibromyalgia are poor sleep, chronic stress. So what is the basis of the stress? It could be that person's had a really tough upbringing. They might have been brought up in a really hostile family. They're in a tough workplace. They've got lots of stress at home. They might have a kid who's got a chronic disease or elderly parents or a partner with some other chronic illness. They're not sleeping. They might be managing 3 kids, running 2 jobs, chronically stressed. That's a perfect cocktail for pain. Perfect cocktail. Now, as a clinician, we've got to work out what are those things that are modifiable and what are the things that are not. So I can't, as a physiotherapist, I can't take away the shit in someone's life. I can't. But I can give them an insight as to why they have pain. I can give them tools and skills to down-regulate the nervous system. I can help them, coach them towards optimizing their situation and their health in spite of that. And so that's a tricky thing because it's trying to work out what are the drivers of pain that are modifiable and what are not. And so that's our job as a clinician, not to say, oh, we can fix your fibromyalgia. It's go, okay, tell me about your sleep. Tell me about what's happening in your life. Tell me about what's happening at work and at home. And maybe that you've got to work with a psychologist to build support around that person to deal with really tough life circumstances, which a lot of people are in.
Yeah.
So fundamentally, potentially these things are modifiable, but it depends on the person's life circumstances as to how modifiable they are.
When you see a chronic patient and you apply CFT, on him or her. Do you ever recommend when there has been some massive improvement and that there's no longer any limited beliefs on the capabilities of movement? Do you then prescribe exercises? Do you tell them to go to the gym?
Oh, I know. So exercise is one of the pillars. So if we describe CFT, right? Number one is making sense of pain. Number two is getting people build confidence in the body to get back to the things they love. Number three is lifestyle change.
Mm-hmm.
Part of lifestyle change is everyone gets physical activity based on their preference. We target issues around sleep, good diet, relaxation, managing stress as one of the key pillars. So everyone gets physical activity based on their preference and their capacity. So it happens day one. So it's not something that comes later. It happens right at the beginning, because engaging in physical activity, there's overwhelming evidence for its benefits for sleep, mood, skeletal health, cardiovascular health, for the nervous system as well. So it is one of the key elements of the intervention. It's not an add-on. It's one of the keys. But what's different is we get them to do it based on their preference. So someone might say, I hate physical activity, but I love to dance. Great, we're going to do dance. They might say, hate gyms, like riding a bike. Great, ride a bike. They might go, I want to swim. Cool, get in the water. So we will coach them to build the confidence to do the things they love. Yep. So it's not about, you got to do this exercise. It's more like, because all the evidence would tell us the best exercise for a human being is the one that they enjoy, that they keep doing forever.
Absolutely.
Could be yoga, could be tai chi, could be whatever, into gym, whatever, lifting weights. I don't know. And literally I will say, tell me the thing that you love, or tell me the thing that you are likely to keep doing. That's the thing we'll aim for.
Mm-hmm. Peter, what training can a physical therapist do to learn about CFT and use it on a daily basis?
Yeah, so actually, good question. There are some different elements here. So I'm going to be in London at the end of this month, and there's a 3-day workshop in London.
So that?
Yeah, so that's one option.
Yeah.
We're actually, as a team, because we published this trial in the Lancet last year, we developed a training program which essentially trains knowledge and then skills and then mentoring. And what we know about dealing with pain, it's not like you can just read in a book and do it. You have to have an understanding of it. You need to develop skills around communication, skills around learning to develop behavioral experiments, skills around guided, behavioral experiments, skills around management planning. And so that's like a second step. And then there's the direct mentoring path. As a team, we're developing a program of training that should become available, we think, sometime in August. So it's pretty close. We're hoping around August, that will give people across the world access to this kind of knowledge and training, because we literally have had requests from over 40 countries for people. And we have a real sense as clinicians and researchers that we want training to be accessible and equitable, because what often happens around knowledge, it's made inaccessible and expensive. So we think this is good for people in different countries, and we know that different countries can only access certain knowledge, and obviously language is a barrier. But now with technology, there's so many opportunities around translation, and those walls are coming down. So at the moment, if you go to our website, which is restorebackpain.com, I don't know if you've seen it, but you can register interest on that website, and you'll get updates of any opportunities that will emerge, because we're working on this at the moment, for developing skills in this space.
Amazing. We'll make sure to put that link onto the description of the episode. Yeah.
Yeah, cool.
So available online training then soon, probably in August.
Yeah.
Amazing.
We've done it. We've filmed it. It's all coming together.
Amazing.
So it's
I'm definitely
it's in the pipeline, and it's something that we've worked really hard. We basically, as a team, we want to create the best learning tools for clinicians to support them, and there'll be free stuff, but for clinicians and for patients, and to support them but we obviously have to fund it, so there will be a fee to accessing some of the learning. But it's pretty cool because actually there's a quiz, so that actually you can test your knowledge. Yeah, it's been thoroughly well thought through, and it's been road tested as well in our trials.
Perfect. Well, thank you so much for your time, Peter. That was a very interesting
It's a pleasure.
conversation.
Yeah.
Thank you very much.
Pleasure. Well, I hope it was useful for your listeners.
Yes, I'm sure. I'm sure it was.
France is one of my favorite countries. Actually, I'm got to let you know, I'm walking around Mont Blanc in July.
Wow.
So I'm in London. I'm in London for a week. I know I'm in the UK for a week, and then I'm at the IFOMP conference in Switzerland, and then my family are coming to meet me in Chamonix.
Lovely.
And we're walking around Mont Blanc for a week.
Oh,
it's one of my favorite places.
That's going to be nice. Yeah,
I'm looking forward to it.
Oh, perfect. Perfect. Well, maybe you should get together, organize a networking event with other physios.
Yeah, maybe.
That would be good. Well, thank you. Thanks again,
Cool.
Peter. And we'll chat to you soon.
Okay, bye.